Okay, thank you everybody for coming. Everybody, I think everybody did Dr. Kiwi. Can I just find out how long you guys have been doing? So who's been doing hearts less than a year? Okay, you're like negative years. Don't worry, you're gonna get to your baseline soon. And then who's been doing less than 5 years? Okay, anybody more than 5 years? Okay. All right, so this talk is just kind of to let you kind of formalize some of the things that we talk about at the bedside to kind of give you our perspective on how we think about heart patients. We have a lot of protocols in place already, but as you can see, not every patient is the same and not every problem is managed the same way, even if you have what looks like very similar numbers. So let's start. What's the most important organ in the body? This isn't a trick, right? Does anybody say anything other than the heart? Okay. Most times when we ask, people will say, you know, they'll mention the brain as the second one. But if we think about it, why is the heart the most important organ in the body?
Because you can live without a brain, but can you live without a heart?
Yeah, exactly, because all the other organs are supplied by the heart, right? There's no organ that cannot live without oxygenated blood. The brain's important. A lot of people mention that because it's important for how our concept of being an intelligent being and interacting. But yes, you could have a live person without with brain death. So if we think about it from an anatomic standpoint, the heart is it's a totally independent organ. It has its own electrical system. So the SA node and the AV node and the pacemaker cells. It does not need a signal from the brain to tell it to work. It tells itself to work. And it feeds itself. The coronary arteries the blood comes from the heart, and those are the first branches off the aorta. So when we are taking care of post-op patients, we always prioritize the heart first. And one thing is that you would think that, okay, we take a patient with any kind of cardiac disease, say coronary disease or a valve problem, and we fix a problem. Shouldn't everything be great? Well, there's a number of reasons that's not true necessarily. And the first thing is that the act of the operation is a big physiologic insult to the body and to the heart as well. So I'll go through a few things that happen in the operating room that impact what the patient is like afterwards and why there's so much management. So first of all, what are the two things we do to do a standard open heart operation?
Bypass, cardioplegia.
Bypass and cardioplegia. When we say cardioplegia, what we really mean is we stop the heart. So bypass, what does that mean? Are you like Reese Witherspoon in the light? Yeah. So Elizabeth, if you all don't know Miranda is our new NP. And Miranda, what is bypass? What do we mean by bypass?
So basically what you do is you have the heart-lung machine and you bypass. Are you talking about the heart-lung machine? Okay. You take and you cannulize the heart. You basically suck out all the blood into the heart. Goes through the machine oxygenates the heart, takes over your heart and your lung function, and then we return it back.
Right. So basically we're creating a pathway around the heart and the lungs, and the heart and the lungs can't really be separated because they're one unit. And this does a couple things. It decompresses and empties out the heart. And that's useful for doing heart surgery because if, you know, cardiac output is 5 liters a minute. If we're going to open the heart and work on a valve, we can't do that feasibly when there's 5 liters of blood flowing in your face. And so it's necessary to do what we call intracardiac work. Why do we do it for CABGs? Well, it also decompresses the heart. That makes it easier to move the heart around and not have hemodynamic changes. And as far as the oxygen demand of the heart, well, if the heart is empty, even though the electrical system is telling it to pump, it doesn't actually have to pump against a pressure. There's no volume there for it to be. So that really reduces the myocardial demand of the heart. And it drops to about 2 cc's per kilogram per minute from a baseline. Resting here, we're at about 8. If you were going to run, it would be about 7. Okay. But it doesn't go all the way to 0. However, the fact that you go on bypass means that a lot of processes are kicked off. And these are things that are learned in medical school. I don't necessarily learn it in nursing school, but your complement system gets activated, There's what we call leukocyte activation and all these kinds of things. But at the end of the day, what happens is you have almost like a sepsis type of picture. You get a big capillary leak. So a lot of fluid goes out to the tissues. And that usually persists for about 1 to 2 days, and then it comes back. So there's a lot of fluid status changes. So we're also managing that after heart surgery. So that's cardiopulmonary bypass. The other thing we do is, here we mostly do things on pump and arrested. There are some places that do a lot of out pump cases. We're not that kind of institution, just because of the complexity of the cases and the patients. So why would we stop them? Why do we have to stop the heart for certain operations? It is easier, so it's easier to sew these small coronary vessels if the heart is not moving.
Would it decrease the oxygen demand of the heart as well?
Yes, exactly, right? So I said it went from 8 to 1 if you empty the heart, and then if you stop the heart, excuse me, I totally messed that up. Okay, so it goes from 8 to 6 if you empty the heart, and it goes from about 6 to 1 if you stop the heart. Because now that muscle does not have to contract, remember the pacemaker cell are telling it to contract. So that really is the main part for reducing the oxygen demand. And then the other thing is, if we're going to work on a valve, especially on the left side, well, if you're going to cut things open, all of a sudden now there's air. Oh, there we go. You're exposing whatever is in the heart to air. Well, you can't have air traveling inside the circulatory system because you have air inputs everywhere, right? So we have to clamp the heart to exclude where you're working from the circulatory system. By clamping the heart, you necessarily stop giving it blood flow through the coronary arteries, right? So that's another reason that we want to stop the heart. It's not getting blood flow, so you don't want it to work.
That's great. Dr. Dewey, you want to, in our presentation here,
For each valve, you have a specific spot, like that you cut, like if you're going to go for the mitral valve, you always try to access it the same way.